Welcome back to our final portion of our September National Vaccine Advisory Committee meeting, and thank you for joining us. Our next session is entitled Respiratory Illness Prevention, Priorities for the Season Ahead. This year, there are several new and exciting changes in immunization landscape. Just in time for respiratory virus season this fall and winter, we have new tools to prevent RSV, COVID-19, and flu. And new no-cost vaccination options like the Bridge Access Program will begin this fall. ACIP is also discussing an RSV vaccine for pregnant women today, so more new challenges could be on the horizon very soon. With new tools to tamp down infections and reduce infection severity, what are the priorities for this season for public health? In this session, we'll hear from Captain Mo Patel at CDC, and then Sarah Dodge-Ramey at CDC. Aaron Burns, also from the CDC, will be available for our discussion to answer questions. Dr. Patel, are you on? I see you. Your slides are up. You have the floor.
Great. Can you hear me? Just doing a sound check.
You are loud and clear.
Okay, great. Well, thanks very much for the opportunity to talk with you about CDC's plan for the fall and winter respiratory season. And in this talk, I will primarily focus on CDC's new vaccine recommendations, what our vaccine coverage data are telling us, and then some of our efforts to improve vaccine access and coverage. Next slide, please. So the goals of the fall respiratory virus vaccine program are to protect the public against COVID-19, influenza, and RSV by making sure they get all their recommended vaccines, promote uptake of vaccines in those at highest risk, communicate new vaccine recommendations quickly, and implement our vaccine programs equitably. Next slide, please. We have several new and updated immunizations, like was just mentioned, the public this season. The updated COVID-19 vaccine is recommended for everyone 6 months and older. It is based on the XBB lineage of the Omicron variant and is expected to protect against the currently circulating variants. Children 6 months through 4 years and immunocompromised people may need additional doses to complete their initial series. Flu vaccine is also recommended for everyone 6 months and older, with September and October being the best times for most people to get vaccinated. To better protect adults 65 and older, there is a preferential recommendation for these older adults to get high-dose inactivated influenza vaccine, a recombinant vaccine, or an adjuvanted vaccine for better protection. And of course, very exciting this year, we have new immunizations for RSV. RSV vaccines are recommended for adults 60 and older under shared clinical decision-making between a patient and a provider. Nursivimab, a long-acting monoclonal antibody, is recommended for infants less than 8 months who are born during or entering their first RSV season, and infants 8 to 19 months at increased risk of severe disease can get Nursivimab in their second RSV season. And RSV vaccine recommendations, as was mentioned for pregnant people, are being discussed and voted on at ACIP today. Next slide, please. So we have come a long way in mitigating COVID-19 since the beginning of the pandemic, thanks in part to the largest vaccination campaign in U.S. history. Almost 700 million doses of the COVID-19 vaccine have been administered in the U.S., with 70% of the U.S. population and 95% of adults 65 and older completing their primary series, preventing an estimated 18 million hospitalizations and saving about 3 million lives. Next slide. Unfortunately, coverage with the recent COVID-19 bivalent booster reached only 17%. And we have a lot more work to do to rebuild vaccine confidence in this country and protect the public against COVID-19, which continues to cause over 20,000 hospitalizations and almost 1,000 deaths every week. Next slide. The other very alarming trend is lower coverage rates for a number of our childhood vaccine preventable diseases since the pandemic started. Fortunately, we are now seeing a few improvements. First, our VFC vaccine orders are returning to pre-pandemic levels. Second, the overall coverage rate remains high and stable among young children. And third, more than 9 out of 10 0 to 2-year-olds have received most of their recommended vaccines. However, improvements are still needed in certain groups of children, especially children living below poverty or in rural areas, where we saw a 4 to 5% drop in coverage for the combined 7 vaccine series. Next slide. For teens, we similarly saw an increase in adolescent vaccine VFC orders. Overall coverage remained stable in 13 to 17-year-olds, but we did see a 4 to 5% decline in men ACWY and Tdap coverage in teens who became eligible for these vaccines during the pandemic. We also saw a drop in VFC orders for HPV vaccine, which is 10% lower than pre-pandemic levels and has not yet rebounded. Next slide. There's been a 2% decline among kindergartners for 2 school years in a row. These are the lowest kindergarten vaccination rates we've seen in over a decade, translating to more than 275,000 children not up to date with their vaccines before they enter school. The 2% drop is seen across multiple different vaccines. And as a reminder, herd immunity for measles is around 95%. The drop in MMR coverage rates puts us again at risk of losing measles elimination in the US. Next slide. There continues to be disparities in vaccination coverage among minority ethnic and racial groups and different geographic locations in the US. This slide looks specifically at rural versus urban locations. By the end of the 2022 to 2023 influenza season, you can see coverage among children 6 months through 17 years in rural areas was 19 percentage points lower than in urban areas. Next slide, please. I actually think this is a duplicate of the previous slide, so you can go to the next slide. Thank you. The pandemic also substantially disrupted influenza coverage in pregnant people. In this graph, each line is a different influenza season, with the earliest season shown as the blue line at the top, with coverage for the 2019 to 2020 season at 66%. This subsequently declined each season throughout the pandemic, with coverage for the 2022 to 2023 season 49%, shown as the green line at the bottom. And so all of these data show increasing vulnerability and widening disparities in the United States to multiple diseases for which we have safe and effective immunizations. Next slide, please. I'll now talk about CDC efforts to address these gaps, because some of the same strategies we use to increase access to routine childhood and adolescent vaccines are similar to the strategies we want to deploy for the fall-winter season. Next slide. So CDC funds 2 existing immunization programs, Vaccines for Children and Section 317, and is proposing to establish a 3rd program, Vaccines for Adults. Now, the 317 immunization program has been in place for more than 60 years and has played a critical role in helping to achieve national immunization goals by supporting the essential public health workforce in systems at the national, state, and local level. The program also purchases routinely recommended vaccines to protect at-risk and vulnerable populations not eligible for immunizations through the VFC program, and to meet urgent public health needs such as controlling vaccine-preventable disease outbreaks. The Vaccines for Children's program supplies over 50% of vaccines for children in the United States, and the VFC is estimated to have prevented 472 million illnesses, avoided over 1 million deaths, and saved nearly $2.2 trillion in societal costs. Next slide, please. The Vaccines for Adults program was modeled after VFC and would provide the 24 million uninsured adults aged 19 to 64 years free access to vaccines. Our data show that only 20% of adults 19 and older have received all their recommended vaccines, leaving a large proportion of the U.S. population at risk for severe disease, hospitalizations, and deaths that could have been prevented if they had been vaccinated. Since we currently do not have a Vaccines for Adults program, CDC launched the Bridge Access Program to provide COVID-19 vaccines to uninsured and underinsured adults. It's a public-private partnership, and the program was designed to meet communities where they are by offering COVID-19 vaccines at no cost at a variety of locations, including pharmacies, local health departments, federally qualified health centers, and through provider networks participating in the Bridge Access Program. Now, while providing COVID-19 vaccines to uninsured and underinsured adults at no cost through the Bridge Access Program is a critical public health intervention, it's only a temporary solution. The Vaccines for Adults program would be a permanent, more comprehensive solution for this major public health gap in the United States by protecting adults, their families, and their communities, especially communities that are often underserved. Next slide, please. So a few brief remarks about CDC's routine immunizations on Schedule for Everyone, or Let's Rise initiative. It was launched earlier this year with the goal of providing actionable strategies, resources, and data to support getting all Americans back on schedule with their routine immunizations. And there's a rich set of resources available online for providers, schools, health departments, and other partners on the CDC website. Next slide, please. The Partnering for Vaccine Equity, or PAVE program, works through a partner network to increase vaccine equity and uptake in racial and ethnic minority communities. And we've seen great success in engaging with community-based organizations to administer almost 2 million COVID-19 and influenza vaccines since 2020. And again, you can find comprehensive guides and resources to improve vaccine uptake in communities on the CDC website. Next slide, please. Before I close, I'd like to remind you of CDC's strategic framework for strengthening vaccine confidence. The goals are to ensure communities at high risk for transmission or severe disease are vaccinated and that no one would be turned away for lack of payment of the administration fee. Second is ensuring healthcare professionals have the right resources to support effective vaccine conversation, since trust is built through conversations between parents, doctors, nurses, and pharmacists, as we've heard during this meeting. And third is to stop misinformation from eroding public trust in vaccines. To do this, CDC works with local partners and trusted messengers who can provide clear information about vaccination and contain the spread of misinformation. These elements work together to achieve the ultimate goal of increasing access and acceptance of vaccines and improving the health and lives of all Americans. Next slide, please. A priority at CDC is to make certain people have timely, accurate, and easy to understand information about immunizations. But we know more needs to be done to build vaccine confidence in this country, and we look forward to our continued partnerships with many of you as trusted sources of vaccine information for providers and the public. Next slide. Thank you, and I will now turn it over to Sarah Dodge-Ramey. Thank you.
Thank you very much. Sarah, I see you on the Zoom and your slides are up. You have the floor.
Good afternoon, and thank you for the opportunity to speak to you today. My name is Sarah Dodge-Ramey. I'm the Associate Director for Communication in the Immunization Services Division in the National Center for Immunization and Respiratory Diseases at the CDC. Next slide, please. Now that we have flu, COVID-19, and RSV, there are 3 respiratory viruses that can overfill hospital beds and strain our healthcare system. We're also facing many challenges in health behaviors, drops in routine immunizations, growing vaccine hesitancy, widespread vaccine fatigue, and because of these things, it's even harder to raise awareness about new vaccines that can help keep people healthy. We also have an opportunity vaccines are now available for all 3 viruses, plus an immunization or preventive antibody that protects infants against RSV. This is not a vaccine. This is an opportunity to leverage communications research to meet people where they are emotionally and in terms of their information needs. We can also try to identify where they are most likely to come across our messages, such as in the digital spaces or outside the home. This really comes down to understanding where different populations are coming from. It's easy enough to say vaccine hesitancy, but everyone has a reason, a story, or a background that we need to consider. Beyond that, it's about changing the narrative. We no longer live in the days of cold and flu season. So it's important that we start shifting the terminology and narrative so that a few years from now, everyone will know it's more than cold and flu. Next slide, please. We are conducting research using multiple mechanisms working with the division, center, and agency. Our goal is to gain insight on knowledge about specific topics, learn which terms best resonate with various audiences, inform our messaging, and develop best practices. Next slide, please. In anticipation of the upcoming 2023-2024 cold and flu season, CDC conducted focus groups to better understand how people think about viral respiratory diseases and baseline knowledge, attitudes, and beliefs in order to inform our communications. There were a total of 12 virtual focus groups, which included general population and parents between June 27th and July 13th of this year. Participants were screened for a mix of health insurance type, gender, race, ethnicity, and educational attainment. Some of the findings included a lack of knowledge and general uncertainty as to what a viral respiratory disease was, specifically which diseases were viral rather than bacterial, and what that meant. Most assumed that a viral respiratory disease was anything related to the lungs, including pneumonia, COPD, asthma, and even strep throat. The term viral respiratory disease season seemed long, unnecessary, and an escalation that felt scary to many. Most participants preferred flu or cold and flu season, or fall and winter. Many participants thought flu season, which was a catch-all phrase that included a range of illnesses, not just flu. A portion of participants reported COVID-19 fatigue and more hesitancy to being concerned about other disease. And the knowledge of RSV was low overall, but there was more concern among parents, though a few older adults also expressed concern. Most participants were open to talking about RSV, even if they didn't want to talk about flu or COVID. Next slide, please. Participants approached prevention to viral respiratory disease as taking a blanket defense rather than anything else specific. There was little distinction between preventive actions for viral respiratory diseases versus non-respiratory infectious diseases. The most common prevention methods were related to a holistic approach to health, like eating well, taking vitamins, and exercising. When sick, participants reported taking precautions to avoid spreading their illness, including staying home when sick, keeping their children home, using masks in public, and using hand sanitizer. Some participants felt that the list of preventive actions were things they already knew, but stated there are people that didn't know them and should learn them. Other participants liked the list of prevention actions because it reaffirmed what they were doing was right. Next slide, please. Vaccines were not a top-of-mind preventive action for most. Many considered them to be a lower priority than everyday common sense measures. There were mixed feelings about vaccines. Some were adamant about getting all recommended vaccines. Some believed they were ineffective or unnecessary, with most landing in the middle of the two extremes. Most participants thought an effective vaccine prevented illness entirely. Some understood vaccine could lessen the severity. When vaccines were included in a list of prevention activities, some people pointed out that listing it first could detract from the value of the list, although they would be okay with seeing vaccines somewhere on the list, just not first. Next slide, please. Some themes across viruses include avoid directives. In general, people prefer softer language around vaccination recommendations when coming from CDC. We know that a strong recommendation is effective when it comes from a healthcare provider. As such, we often play around with different calls to actions, like talk to your doctor, find out about where to get vaccinated, or talk to your doctor about X vaccine. Educational messaging is a door opener. We have found that people preferred simplified, brief information, but enough that they feel that they have enough to take action. Generally, we want to try and incorporate brief messages about risk, why the vaccine is needed, what the beliefs are or the benefits are, and where they can go to learn more. Again, they like to feel empowered to learn more and do their own research versus being told what to do. Avoid messages that could be seen as a scare tactic. Set realistic expectations. People are more likely to perceive messages as credible and trustworthy if they set realistic expectations about what vaccines can and cannot do. This is one reason why our flu campaign's wild to mild concept performed so well in testing. It clarifies that people can get flu if they're vaccinated, while emphasizing that the vaccine still offers benefits even if you get sick. Consider marginalized communities. There are times where we are not always the right messenger, and partnerships with groups on the ground can be more compelling. We often hear that healthcare providers are the most trusted spokespersons for vaccines, so we're developing tools to help them navigate conversations with their parents. And lastly, set realistic expectations. People are more likely to perceive messages credible and trustworthy if they set realistic expectations about what vaccines can and cannot do. Next slide, please. This slide shows NCIRD's fall vaccination outreach as a whole, including back to school and the respiratory virus efforts, which include the Bridge campaign that I'll get to more in a minute. Next slide, please. The Back to School Childhood Vaccination Campaign kicked off the week of July 10th, with campaign materials deployed and partner engagement toolkits disseminated. The flu campaign had a soft launch of their digital assets and market in mid-August, with a media event on September 6th with the CDC director, and the kickoff being September 28th. The campaign runs mid-August through February of 24, with the focus being on parents of children 0 to 17 and pregnant people. Aaron Burns, ADC of the Influenza Division, is with us today for any additional questions you may have about the Wild to Mild campaign at the end of the presentation. Next slide, please. So what are the COVID-19 outreach activities? We're currently working on the COVID-19 Bridge Access Program, a program for uninsured and underinsured adults, which is underway now. We shared a communications toolkit this week with partners, prepared organic social media to go out on a rolling basis. IDIs were completed this week, and we will have the results next week to inform the larger campaign that we will be launching soon. NCIRD is also working on activities around a general pan-respiratory season, which includes flu, COVID-19, and RSV. The plan is to kick off in October to the general adult public, including families and older adults and healthcare providers. We currently have materials in testing and development, including healthcare provider-specific outreach, social media, digital video spots, and the development of a partner toolkit. Next slide, please. This timeline has changed a bit, but you will notice most of the spikes are in September, including an event that we had on September 6th with the director where she received her flu vaccine. The new 2023-2024 COVID vaccine being released last week, and the flu vaccination kickoff next week. Next slide, please. Thank you so much for your time this afternoon.
Thank you. I want to thank both of our presenters from CDC. I think the Bridge program and current availability of all three of these respiratory vaccines are critically important for our society as we get into this fall. But I'm also hearing a number of barriers and challenges from providers and from patients in the trenches. Challenges with private insurance refusing to pay for the RSV vaccine, for nirsevimab, and for COVID-19 vaccine because they're not in the published schedule. I think we need to really think about the issue of the grace period where private insurances are allowed to not pay for ACA mandated vaccine coverage for a period of time. But I'd welcome your comments on those issues.
Yeah, I can start. And, if CMS or AHIP is available to come, it'd be good to hear from them as well. And I'll also say this exact conversation is happening at ACIP right now. A lot of questions around the very complicated landscape of healthcare in the United States. So COVID-19 vaccines, like you said, they are required to be covered now. Whether it's the ACA or the Inflation Reduction Act, those different timings, that was all benchmarked to December 2020. So all of those sorts of time limits have already expired. Having said that, like you mentioned, the actual implementation is challenging. And we are also hearing that providers or, pharmacists are, insurance companies are requiring patients to pay for their vaccines, and providers are actually concerned that they're not going to get reimbursed. And so I would defer to, if CMS or AHIP is on the call today, maybe they could provide some comments. And again, also very complicated for the other vaccines. It depends on which payer you have. Are you in network or out of network? So just want to concur, it's complicated.
Right. Mitch Rotholt's on the line.
Yeah, Bob, I was just reiterating what was just said in terms of payers who aren't updating their systems. For example, with COVID, they're still treating it in their system as if the government was providing the vaccine and haven't changed over to commercial. And it's causing a frustration by patients and the providers. Patients ready to get vaccinated and providers concerned about being stuck with the money like they have in other programs. And Bob, I just want to reiterate the point you made on RSV, because we're seeing that a lot. And not only from a payer perspective, but from authority at the state level, at least for pharmacy, in some states, they require it to be published on the schedule for pharmacists to be able to do it. So there's a delay there. That's why I called the other day for a look at the implementation process once something comes out of CDC for recommendations, and again, reiterate the need for a buffer so that we have time for implementation.
And I'll just add, the specific question about the barrier for the schedule is being addressed this afternoon at ACIP as well. And so we do expect at least that barrier to be removed, but I anticipate there's going to be ongoing barriers from the actual front line.
Yeah, Minister, thank you for that. And I think the other part is looking at from CMS and the administration of what other, I would call it enforcement, what other encouragement can the government give to the plans who are, they'll say they're covered under ACA, but if you're not an in-network provider, if you're, you're not in their list, then they don't cover it. So that becomes a barrier as well. So I think not only the guidance that CDC and CMS put out earlier about being able to start implementing, a good number of plans did not even follow that. So there needs to be some stronger enforcement to put that in place, unless we're going to continue to face these obstructions. And thank you.
Claire Hannon.
Hi, it's Claire Hannon from the Association of Immunization Managers. And I just a huge thank you for the Bridge program. Just amazing to set something up in such little time to have an opportunity for uninsured adults to access COVID vaccine. Just amazing. And the vision for having a retail pharmacy program as well as a public health program, with the retail pharmacy program using their own vaccine and getting credit. So, the shipping issues aren't there. Just really great. I just wanted to comment that, I hope that you are able to document some of the challenges with getting the contract in place with pharmacies and the timing that it took. Being outside the public health emergency, I think it took CDC and pharmacies much longer to go through some of that red tape. And so that's something perhaps in the future to be considered when we're not in an emergency situation, but we're unveiling, for example, in the Vaccines for Adults program moving forward, like having the ability to cut some of that timing that it takes to contract with pharmacies and private entities to be involved in a government program. And then just a comment too, that because of that, the pharmacies have vaccine right now, and the public health side is receiving vaccine. It's being shipped out. It's turned around very quickly. The provider enrollment and all of that. I think it's been great, but it's still potentially a little bit of lag, right? Like a few days. So it would be great if some of these things get documented, and as we move forward and do these programs in the future, the successes around putting this vision into place and the challenges can be captured and addressed. But thank you so much for this program. I'm really excited about it. I would also comment about the insurance covering, Nursivimab and the RSV products. But yeah, those challenges, you recognize them. And I think Mitch Rotholtz made a really great suggestion earlier that, looking more closely at some of the implementation challenges and talking through them would be really helpful.
Rob Schechter.
Hi, I think Claire covered a lot of the ground I was thinking of too, and again, the thanks for the Bridge Access Program. I did have just one comment on the Bridge Access Program is that while doses have gotten out there, they aren't out as widely as an expectation that from some of the messaging that vaccine is available broadly, and I realize that's a hiccup that will get solved in time, but I think it reflects a challenge of trying to capture early interest when supplies may not be able to meet all that interest or result in the frustration of having to call around to a number of places or locate that available supply. I did want to ask you for a clarification of which barrier of RSV vaccine or Nursivimab you expect to be addressed today at the ACIP meeting. I didn't quite catch which aspect of that, and also a plea for what can be done to incentivize or payers to cover Nursivimab as quickly as possible. Hearing now from both our birth hospitals in the state of California, many of which are reluctant to bear that cost before reimbursement. Similar concerns on the outpatient side. And I can imagine the same for prenatal providers for the RSV vaccine. And so shared reluctance and wondering what the other partners in the mix are going to be doing, and seeing RSV season coming upon us shortly, if not here already, and wondering how to protect as many infants this season as possible. Thanks.
Yeah, thank you. And again, just listening to the ACIP discussion, that there's even more challenges that are being aired. So, for example, we know that 50% of children in the U.S. are covered by VFC. So for at least half the nation's children, they should be covered. One challenge, though, is that most hospitals, and Dr. Schechter, you might actually know this already, is that they're not VFC providers. And so how you onboard birthing hospitals is a challenge. The product availability, we don't have it on the shelves yet. It's supposed to be available in the next couple of months, but we're already entering RSV season. As you know, Florida and the Southeast is already seeing an uptick in RSV disease activity. And so some of the other sort of barriers I also think is just the communication around Nursivimab versus our maternal or RSV vaccine for pregnant people, and if there's going to be insurance coverage issues if a mom got RSV maternal vaccine, but we don't have records, and the pediatrician's not sure now what to do about NMAB. So there's a list of different things that many folks are working through. And I think the earlier question you had about what's being discussed today, I'm trying to remember what I said that made you think that. But the one thing is just that all of this stuff that's going to be on the actual immunization schedule, all of these different new recommendations, updated sooner than typical updates in the spring, I believe. And I can see if Sarah, did you have anything to add from the implementation side?
No, not right now.
Okay.
Thanks.
I think Mitch Rotholtz had some additional comments.
Thanks, Bob. So a couple of points. One, we are hearing differentials in what providers are paying for the COVID vaccine based on the type of provider they are and not being able to purchase directly from manufacturers. So that's starting to circulate within the provider community. And then in general, in approaching the discussion with patients, I heard an interesting approach. I just wanted to get your take on that in terms of not leading with asking about COVID, but one of the other two respiratory vaccines, and then ask about COVID. Any thoughts on in terms of providers that we see any data in terms of the best way of approaching the discussions?
Yeah, I'm curious, Sarah, if you found anything. So you're talking about acceptance specifically in terms of that conversation between the patient and provider to encourage uptake. Sarah, do you know if the sort of sequencing of those vaccines in the discussion might increase uptake?
I don't know. I don't have the answers from our HOXO stuff. I don't know. Aaron may, and I know Aaron's on to answer questions as well.
She might not be able to get off mute. We can circle back and see if there's any data on that. Yeah.
And then one of Bob, if I could ask one more question.
Please proceed, Mitch.
Okay. And then in terms of the bridge program, we've got some startup hiccups and all that, but the question I keep on getting from folks that keep on asking is, we had a federal retail network in place for the bridge before the bridge program, and the question keeps rising: why did we go back to starting out limiting the providers for that versus using the existing network? Because we had a lot of providers who worked in that network and did some yeoman's work during the pandemic, and then all of a sudden they're cut out. So there's a lot of questions floating in the community, and it's, as a matter of fact, it's causing some people to double think their involvement. So just curious of why we had to go to a separate contract versus when we already had a network in place.
Yeah, I'll see if Sarah has more maybe more insight into this, because she works in the immunization services division. My understanding, it's just the way the contracts work, that CVS, Walgreens, and eTrue North are part of the new contract. One of the issues too is one of the pieces of designing the bridge program was to make sure that the locations of these different pharmacies would be far reaching. And so there was a mapping that was done to ensure that, for example, rural areas would be, included as part of the equity lens. So I don't know all the details of how that actually rolled out, but certainly the three pieces of the Bridge Access Program was, one, just making sure vaccine was available at no cost, specifically COVID-19. And I think everyone knows that Bridge Access is only for COVID-19 vaccines. Number two is that location piece, accessibility, that adults who were uninsured or insured had a pharmacy location close to them. And then the third was increasing vaccine confidence. So unfortunately, I don't know all the details of the contractual piece of that, but Sarah, do you have anything to add there? And we can certainly get back to you.
Yeah, for the contractual part, I don't, but you're absolutely correct in the three things that you said. And one of the big things was Walgreens, a large percentage of the American population is within 5 miles. So that played into it as well. But as for the contractual part, no, I don't know, but we can get back to you on that.
Okay, I'd like to discuss that more with you guys, because you had that in your federal network. And while I work and applaud Walgreens and CVS, you had a lot of rural areas that weren't necessarily covered well. That's what we started out in COVID with, and we had to expand the networks, and we had a good network that covered those areas. So that's why the questions keep coming up. So that's why I just want to make sure it got on the record that we need to look at that.
Yeah, and Sarah, you might know this, that for eTrue North, it's where the small one, and again, thank you for the comment about the federal network that was already established. It's a good question. We can dig into that. My understanding is that now a lot of these rural pharmacies are connecting with eTrue North to provide that service for connectivity across the country.
They're having to step up the network. They didn't have it in place. So that's why a lot of questions are coming up.
Gotcha. Okay. Helpful. Thank you.
Well, I want to thank you very much for your presentations. A lot of good discussion here. Again, it reinforces the fact we're all in this together. We've all got to continue pulling toward the same goal of vaccinating and protecting our society for respiratory season, but also to catch up for the drop-off in influenza immunization rates in groups, and to catch up our kids and adults for the vaccines that were missed through the last 3 years. Thank you for your efforts. Our final presentation for today is meningococcal disease type Y outbreak in Virginia. Virginia Department of Health is responding to a community outbreak of meningococcal disease type Y. In this session, we'll hear about the response, challenges, and barriers to vaccination. Dr. Lori Forlano is the director of the Office of Epidemiology and the state epidemiologist for Virginia. She'll be our featured speaker for this presentation. Dr. Forlano, we'll have you come to the stage, and the floor is yours. We'll even let you catch your breath first.
I was lucky, a former Virginia colleague now works in this building, so I just got a quick second to see him. Hi, good afternoon. Honored to be here today. My name's Lori Forlano. I serve as the state epidemiologist in Virginia, and I also direct the Office of Epidemiology at the Virginia Department of Health. And my office has purview over largely the communicable disease surveillance, prevention, and control activities at the health department. And that includes our immunization program. It also includes disease surveillance, prevention and control for all reportable conditions. I represent a team of many people whose work will be described today, including our immunization director, Christy Gray. And I also wanted to acknowledge my colleague, Meredith Robinson, who's in the seats in the back. She's our vaccine preventable disease epidemiologist. Go to the next slide, please. Got it. Okay. So I hope today I'll be able to describe the trajectory of an outbreak we've been responding to when I was reviewing the materials this morning for exactly 1 year today, which is an interesting coincidence. So we've been responding to a statewide outbreak in Virginia since last September. Just to orient you to how the public health system is organized in Virginia, in the upper right-hand corner of your slide, you'll see that we're organized in 5 health planning regions in which we have 35 local health districts or local health departments in Virginia. 33 of those are affiliated with state government and the state health department, and now actually we have 3 independently administered health departments. The sequence type associated with this outbreak was identified in the eastern region of Virginia, which is in that yellow color, in June of 2022, and it's since been detected in the central region, which is in light blue, and the southwest region of Virginia, which is in dark blue. To date, we have 27 confirmed cases that have been reported of meningococcal disease, including, unfortunately, 5 deaths. All isolates that have been available for sequencing at the time these slides were prepared, it was 22 out of 27. Now I think we have 25 of 27 isolates that are available were found to be the same strain, which is sequence type 1466 with clonal complex 174, and those are considered highly genetically related. The graph on the screen is showing, just to give you some background and context over time in prior years, shows the number of meningococcal cases reported to Virginia each year, which and this is inclusive of all serogroups. On average, it was about 8 cases a year. You can see that jumped fairly significantly in the last year. Our outbreak crosses calendar years. Cases of serogroup Y increased 7 times since 2022, with the majority of those cases being linked to the outbreak being described today. We explored our data for these cases, the outbreak-associated cases, in regards to a few characteristics: demographics, clinical presentations, vaccination status, and case fatality rate. As you can see in the bar graph on the slide, the majority of cases have occurred in Black or African American residents of the Eastern region between 30 and 60 years of age. Of note, serogroup Y is most commonly detected in adults 65 years of age and older. The Department of Health in Virginia has not yet identified a common risk factor among our outbreak cases. Most case patients, 18 of the 27, presented with septicemia rather than meningitis, with common symptoms including fever, nausea, vomiting, diarrhea, and muscle aches. 5 of our case patients associated with this outbreak have died from complications of meningococcal disease, indicating that this strain might have a higher case fatality rate, 19% in our outbreak, than is commonly observed in serogroup Y cases, which we understand averages between 10 and 12%. 26 case patients of 27 were unvaccinated for serogroup Y. And we'll acknowledge that most of these people were of the age where the quadrivalent vaccine recommendation was not in place, when they were children or adolescents. One case patient had received 1 dose of meningococcal polysaccharide vaccine over 10 years prior to their symptom onset, but otherwise the majority of cases were not vaccinated. And of those cases that would have been routinely recommended to receive the meningococcal conjugate vaccine due to certain medical conditions, such as a person living with HIV, none of those persons had record of vaccination. So this began as a community outbreak. We first announced a community outbreak of meningococcal disease, serogroup Y, in that eastern region of Virginia, so that yellow portion of the graph that was up there earlier, and that was announced formally in late September of 2022. As the outbreak continued, we did do some outreach to healthcare providers, also the public, in the spring of 2023 in March, including standing up an outbreak response website on our VDH webpage. Following the detection of the outbreak strain in additional regions, so Central Region and Southwest Virginia, we did make the decision to announce a statewide outbreak on August 30th of 2023. So that's a fairly recent development. And we also included additional vaccine recommendations when we made that announcement more publicly. Providers at the time were advised to maintain a high level or high index of suspicion for meningococcal disease, reminders about ensuring routine administration of vaccine in adolescents and teens, and encouraging vaccine for persons who are at increased risk of meningococcal disease due to medical conditions in accordance with ACIP recommendations. We did do some focused outreach to HIV care providers. We did that primarily in partnership with our Ryan White program at VDH, as they have very well-established relationships with that clinical community. We've done some phone calls with some of the clinical advisors we have to the Ryan White program, but just in that network in general, just reminding them of making them aware of the increase in meningococcal disease and emphasizing the importance of timely administration of the vaccine for their patients. We do continue to respond, as we would even outside of the context of this outbreak, to reports of meningococcal disease. We work quickly to rapidly identify close contacts for whom short-term antibiotics are recommended for post-exposure prophylaxis. So that work continues if we receive reports of cases. As I mentioned earlier, we have not determined a common risk factor for these cases, which has proven to be challenging when we start thinking about a more targeted or focused vaccine strategy. We began recommending 1 dose of the quadrivalent vaccine for close contacts I will note that excludes healthcare personnel, just general public close contacts, in addition to post-exposure prophylaxis. In December of 22, which was just a few months after the onset of the outbreak, we recommended 1 dose of the vaccine to close contacts who are in a certain age range, 30 to 60 years old. And that was originally based on the outbreak epidemiology at the time. In the spring or May of 2023, we expanded that recommendation to include all close contacts down to 11 years of age and older, as cases outside that original age range were identified. And that was all in the eastern region at the time of the state. This recommendation was applied statewide more broadly in August of 2023. Our intent there is to vaccinate people, or make an effort to vaccinate people who may be a part of an unknown social network at increased risk for potential future exposures to Neisseria meningitidis. As I'm sure you all know, CDC does not routinely recommend vaccine for close contacts of meningococcal disease cases, and there is not evidence that the vaccines currently licensed in the US affect the asymptomatic carriage of the organism. However, we understand that vaccine is recommended for household contacts in the EU member states by their equivalent of CDC in the EU. So that, combined with many other considerations, we felt like it was a prudent step. I appreciate the prior panelists. I think some of the themes will ring true here as I briefly describe our vaccine strategy and efforts there. Uninsured, so we have had some successes. Uninsured contacts are provided vaccine free of charge. We fairly quickly tapped into our the 317 vaccine program to help make that happen. Our close contacts are also provided materials on the vaccine, education on signs and symptoms, how to prevent transmission. Our local health department staff held vaccine clinics in some communities. In some instances, met in person with those social contacts. In some communities, for example, they met with faith-based communities or church congregants to raise awareness of the outbreak in the local community and to try to promote vaccination. Limitations or challenges that we faced, which are unfortunately probably not unique to this outbreak, are a general theme of fatigue with vaccine following the COVID-19 pandemic. And I think just generally, I think I heard the prior speakers mention that too, just kind of a general state of overwhelm of all the vaccines and all the things. Uninsured or underinsured close contacts did and continue to cite concerns about vaccine costs. I think in most cases we're able to mitigate those concerns with some explanation and information. Some of the close contacts when interviewed were not aware of our ongoing outbreak, so that was a lesson learned for us to how to better communicate and penetrate that message down to local communities. Some of the contacts agreed to receive the post-exposure prophylaxis, but declined vaccination. And in some cases, some of the case patients or their representatives or proxies denied being a close contact and did not want to provide information about themselves or other persons in their network. And the image on the screen, I do want to acknowledge a partnership that was done locally through an organization. It's actually a meningitis B action project. I believe it was a mother who has interest in this topic, and even though it was a different serogroup, she definitely wanted to help out, and the organization helped us put some educational materials together to disseminate. In late August, local health districts, that's our equivalent of health departments in Virginia, that have reported an outbreak case are recommended. So we have convened our local health partners. We've recommended that they provide 1 dose of the vaccine to adults with certain medical conditions, and where it's relevant, to also offer vaccine to residents of localized areas experiencing transmission. That is not, the latter is not a factor in all of the communities from which cases have been reported, but it has worked in certain areas. The communities where cases have come from definitely vary. There are some more urban communities, there's very rural communities. In the more urban area, the one I'm thinking of, they identified 3 outbreak associated cases that lived very close in proximity to each other, neighboring census tracts. So it felt relevant and warranted a more targeted, focused geographic vaccine campaign. That was not the case in some of the other communities where cases were reported from. For persons at increased risk of meningococcal disease due to medical conditions, you can see on the screen our recommendations there. We really were encouraging our local health departments to echo the messages we were giving to certain clinicians and clinician communities to make sure that people at higher risk of severe disease were brought up to date with recommendations. I think I already spoke to the localized area approaches. In one community, there happened to be a public housing complex in the neighborhoods where we were seeing cases, so they were able, and the local health department already had a pretty well-established relationships with some organizations there, so they went through those avenues at a minimum to make sure that information was being shared. So we've had, I'd say, a lot of effort. I think the success with the campaign is still to be seen. It's proven to be very, very challenging, and the uptake of the vaccine in response to the outbreak, I will admit, is not as high as we would like it to be. Our vaccine data team is really trying to dig into the data we have to try to figure out how we can do a better job there. But it's a fairly recent evolution of our approach, so I hope that that will improve with time. And I'm happy, I would love to hear insight about how to improve that, and happy to answer any questions.
Well, thank you. Unfortunate to hear about the outbreak, but we appreciate your bringing this to the committee. Rob Schechter.
Well, thank you for all the work you're doing around this outbreak. And I had a couple of questions. It sounds like the pace of new cases, is it subsiding or?
No.
Okay.
No, is the short answer. We are waiting on some sequencing data of a couple cases, so we haven't technically counted them yet, but we are continuing to receive reports.
And I was curious about a couple things. You mentioned your strategy on localized districts, localized cases. Mm-hmm. How many of the 27 confirmed cases have fallen into that localized versus diffuse?
I might rely on Meredith, but I think the majority, because the outbreak did originate in the eastern region. Meredith, do you want to comment on that? The number of cases that were in Portsmouth, that more localized area.
Yeah, hi, it's 3 cases were found within 3 census blocks of one another. So they're very close together, within half a mile, I believe, of each other.
Mm-hmm. That was the only place, if I'm remembering correctly, where we saw that geographic proximity.
Yes, that's the only part of this outbreak where they're clustered that closely together.
You mentioned all the things you look for. Is there any smoking history or tobacco as a risk factor?
I don't think we looked at that. Did we look at smoking?
Yes, if I can say, we have the majority of cases have a history of cigarette smoking.
Mm-hmm. Majority do.
Yes. Majority of cases have a history history or current smokers.
Oh, okay. And was there seasonality? Was thinking about this triple-demic that we've been talking about, whether past links with meningococcal disease and prior respiratory viral infections, but it sounds like it's been.
Do you know the answer to that?
Summer, fall, winter, spring, and it hasn't necessarily correlated with.
Mm-hmm.
We were concerned about an increase in the winter, because I know meningococcal disease can peak in January and February, but we did not see a correlation in this outbreak. It did continue through that period, but it did not see a seasonal increase.
And a last question was, I know it's very uncommon to have colonization studies, but do you have a feel for whether community prevalence of the strain or any colonization data?
Go ahead, Meredith.
I
don't.
No, we do not have that. I'm sorry.
Well, thank you again for your presentation.
Sure.
Please.
very important work you're doing. Thanks for the update. We all think that this is mostly transmitted by just person to person. But it's interesting that you're seeing these groups, and it's an unusual outbreak. And smoking is associated with it. I wonder about vaping products or even anything licensed that people might be using that could be contaminated. Has this ever been seen before? I don't know. I don't know of any reports.
There have been, I guess I'd call it statewide outbreaks declared in, for example, in Florida, but that was in a very particular population, which is not the case in Virginia. And my understanding is that this is this first statewide outbreak that's been declared, in at least in recent years. I don't know how far back. That's what CDC advisors told us. It's been a very challenging. There's a lot of judgment being applied in some of our decision making because the cases continue to pop up, and we're having difficulty, as you do with these things, in identifying a risk factor. And Southwest Virginia is 5 or 6 hours drive from the eastern coastal region of Virginia. So we thought really long and hard about whether or not a statewide outbreak was the appropriate response, but in the end, especially because of the pace of the cases we continue to see, I think that was appropriate. But to my knowledge, it's not been seen like this in other areas. I should also acknowledge our state laboratory and their partnership there. I meant to do that earlier.
Melody Butler.
Thank you for the presentation. I have one point and one question. My first thing I want to say is thank you for using that graphic from the Meningitis B project. Those are two of my colleagues, Alicia Stillman and Patty Wilkowitz, who unfortunately did lose their daughters to meningitis type B of college age in high school. So on that note, has there been any outreach to the college communities and the college campuses in regards to helping that particular population? And I was curious as to, I know you said the average age was 65, but what was the age span? And what was your youngest patient and your oldest? And was anything in long-term care facilities? Thank you.
I think the answer to long-term care facilities is no. The age range, Meredith might know at the top of her head.
The age range is 16 to 80. The median age is 43.
The 16-year-old didn't gotten in?
No. Unfortunately, no. And I think we weren't sure if the pandemic played into that, if the time she would have received it was during pandemic, during COVID, yeah.
So this is a younger outbreak. You're seeing the average age is in the 40s.
Yeah, younger, right, age 30 to 60 years is where the majority of our cases are lying in that age range, which is a younger age than you would typically see in serogroup Y cases, yes.
And are the college campuses, are they working with you? Are they? I
think I'm trying to think of the college campuses that rest within the communities that from which we've received cases. I will say that the local health departments do have pretty robust, and actually this is a silver lining from the pandemic, is that those relationships with institutes of higher education were pretty solidified during the pandemic, so they are working with them. I don't know if they're doing that necessarily because of this outbreak, but more just as a routine practice. But Meredith, correct me if I'm wrong there.
I believe the Eastern Region local health departments have been working with health partners at the universities. But there's been some outreach about possibly just encouraging those college students who are already recommended to receive this vaccine routinely to ensure they are up to date.
I meant to also note, Virginia made the meningococcal vaccine a school requirement just in 2021. So we do expect to see uptake impacted by that. It happened in the middle of the pandemic, so I don't think we've seen the results of that quite yet, but I think we will in future years for that younger age cohort. And most colleges in Virginia require it as a condition of admission.
Well, thank you all very much for this presentation.
Thank you.
I want to step back for just a moment. We did get a response from Aaron Burns to one of Mitch's questions about whether there was any data on offering flu vaccine, COVID, or RSV vaccine. The ordering of that changed acceptance. Her comment was that acceptance of flu vaccine is higher than the other two, but there's no hard data on sequencing recommendations making a difference on uptake at this point. And we have reached the end of our formal agenda. It is the time for public comment, but we do not have any public comments online today. I do want to remind the committee members that Anne has distributed a written public comment to all the members of the committee that was submitted to us previously. And if other written comments come in, she will submit those also to the members of the committee. I want to thank all of you all for your participation, either watching the web stream, participating in the web stream, or being here in the room with us. This brings us to the conclusion of our September 2023 NVAC meeting. I appreciate the members, those that have watched, those who have given presentations, and certainly our NVAC team for supporting us. I wish you all safe travels and a nice weekend, and look forward to seeing many of you in February for our next meeting. We are now adjourned.
Produced by the U.S. Department of Health and Human Services.